So I don't know if I should have gone first or I should have gone second in this program today. And I thought that was a great lecture, and I'm going to have a tie-in to that because I'm coming from the surgical aspect of this unique procedure that's sometimes been controversial in some of the presentations and some of the meetings. So I need to make some clarification that I will try to support my comments today by evidence-based dentistry, or I'll have an opinion, or when I was a resident at UMKC, I learned the term SWAG. SWAG means scientific wild-ass guess. Most of the patients have consulted and consented to the modeling for their photos. Images are edited for visual clarity. I am a paid consultant with Noble Biocare, and I'm on their key opinion leader, so I needed to tell you that. We will talk about an evidence-based approach. Ron Nevins, in his opening comments, suggested maybe evidence-based dentistry doesn't exist. I'm going to support the concept that I think it does exist, and I think it is a good thing for patients and the profession. I'm going to talk a lot about non-grafted solutions, especially how All-in-4 fits into the non-grafted loading protocols, and as our last speaker did a wonderful job, showed biomaterials. And I'm going to come to that from the periodontist standpoint and the maintenance standpoint. So let's talk about philosophy first. I think it's important because when we go away from these meetings, if we don't see a philosophy, we don't generate a philosophy, and if we don't have a philosophy, we don't execute when we get back. The truth is, there are a tremendous amount of patients who are edentulous in our population today. This is a report from the ADA, 26% of patients 65 to 74, so that's a lot of people. We know from some consumer research, over 50,000 consumers were researched and interviewed by Noble Biocare. We found that 50% of the patients have a gross misunderstanding or misrepresentation of what a total dentulism is. They think, the patient, it is a long, drawn-out process that is wrought with a lot of pain, despite what we might believe in this group of distinguished dentists, they have fear of us. We know there are consequences to non-treatment, at least they think there are, and people are judged by their appearance and judge other people by their appearance. We have to justify beyond costs the appearance and function, and how can we motivate these large group of patients that have these misconceptions. I sit back like you do in this audience and I look at the beautiful dentistry that's done. And my question is that the norm of the patient that I see in my practice? Several of us were commenting on some of the photographs of the unusually beautiful men and women presented. In my town, that's what I see. That's the population that I'm treating. I mean, my patient population is 45 to 70. To give you a perspective on this, I told the story in the hands-on session. I have a patient who happens to be a friend who's now 82 years old, living in an assisted living facility. I saw him at the country club. I said, "John, how you doing?" He says, "I'm doing great." He says, my wife's dead. I live in assisted living. And he said that, I can walk up to the country club. I can have lunch. I play 9 holes of golf, and my life is great. And I said, "Well, that's great." I said, "What's it really like in an assisted living home?" He says, "Well, let me tell you." He says, "I'm a widow. There are a lot of women." And I wasn't expecting that out of him because I've known him. I knew his wife. And he says, "Yeah, there's a lot of women." He says, "They're moving in all the time." He says, "Last week," now this guy's 82. He says, "Last week, a 75-year-old woman moved in." I said, "Well, that's great." He said, "Yeah, and she's got the body of a 60-year-old. And I thought about that, and it was humorous. I went away crying. I told everybody at my office that story. But think about it. How many 65-year-olds or 75-year-olds want the teeth of a 40-year-old or a 20-year-old? Because that's my population. I also, it wasn't stated in my bio, but I came out of the Air Force, and I treated a lot of people from Vietnam and Korea when I was in the Air Force, and now today we have a lot of veterans from the Gulf War and Afghanistan and Iraq. And a lot of these young individuals, unfortunately, have been injured and lost limbs. And fortunate for us today in orthopedic rehabilitation, we can actually rehabilitate these patients to the point where in the Olympics recently, the Blade Runner was considered to have an unfair advantage. So orthopedics is doing a wonderful job. We in dentistry are faced with these challenges. The first patient, you might say that's total edentulous. In Missouri, that's a fully restored patient. We have Meth laboratories, we are the capital of the meth laboratories in the world, in Missouri. We have patients who have had extractions, and we do have patients who have sought minimally number of implants to solve a problem, and we know that some of those patients are very successful, but sometimes they want an upgrade. So they come to us for upgrades. Unfortunately, this is a common occurrence in my practice. We see patients, this lady's 51 years old, she lost her teeth at 19 years old in the maxilla, and she's had 5 sets of dentures from 5 sets of dentists. And every dentist that preceded the next dentist told her what? I can make you a better denture than the last dentist. I have these teeth. I have this impression technique. Christian, I have this laboratory guy that can make you the best denture. The truth is, a denture is a denture is a denture. And we know the consequences of long-term edentulation is loss of bone, loss of facial structure. That is the consequences. So my choice as a dentist, philosophically, is which do I provide my patients? And this is what the profession, in my opinion, and educators and universities are faced with today when they're teaching prosthodontics, or complete prosthodontics, to their students. Do we continue to teach people how to make dentures, or do we continue to teach and lead students towards the rehabilitation of patients as our orthopedic colleagues are doing for our amputees? That takes a moment of silence to think about that, doesn't it? I think the profession needs to move forward. And my philosophy is based on Peter Segnier's book, Structure Influences Behavior, but Behavior Gets the Result. My behavior and my belief from my mentors passed to me, and in 34 years of being a periodontist, is either I'm going to save the bone by saving your teeth, or I'm going to save the bone by putting implants in, and I'm not going to give you a crutch. I'm not going to give you teeth that sit in a glass at night. I'm going to give you teeth that act like teeth, chew like teeth, and are inside your mouth at night. That's not to say that overdentures couldn't be possible solutions for patients, but in my philosophy, I would probably do everything humanly possible and financially possible to give the patient an opportunity to have a fixed prosthesis. And my world is, I'm not Team Atlanta or Team New York, Dennis. I'm Team everybody in St. Louis. My world, I've had the opportunity for 34 years to have wonderful referrals from my colleagues in my community. And I know a lot of you in this room don't have Team Atlanta. You have Team Cincinnati. You have Team Boston. You have Team somewhere else. And to be frank with you, I'm a little jealous when it's Team New York or it's Team Atlanta. That's a tremendous advantage. But I also have had advantage of dealing with a lot of people. These guys, Dr. Garber, Dr. Salama, everybody in this room, back to Christian back there, have strapped me up. A number of years ago, I did a very controversial panel with some of the most prestigious dentists in the world and laboratory technicians, and these guys stood behind me, so I remember that. Also, I've had the benefit of having tremendous corporate support. I can't believe you guys gave away a $200,000 CAT scan last night. I mean, folks, that's incredible, the corporate support that's been given in this room. And I've been given corporate support. So the reality is, I've done none of this myself. This is all by the benefit of, the help and procedures that I'm going to show you now. I've learned from other people, and this is the all-in-4 procedure, this controversial procedure maybe. 4 implants placed, maxilla or mandible, 2 anterior implants are parallel, 2 tilted implants, and then a screw-retained fixed prosthesis of many designs. Now let's talk a little bit about prosthetic rehabilitations. He talked about what was on top. I'm going to talk about what's on the bottom. And because my implant training started with total edentulation, I'm going to emphasize these types of restorations with these types of surgical procedures. The first patient comes to you with a failing dentition, not only periodontal but restoratively, and caries. He's looking for another solution. We have options. The option that we chose for this one, for those of you who've gone through Mish's program or are a Mish devotee, Carl would like to see multiple implants. He'd like to minimize distal cantilevers. So I think this is a very reasonable approach for this particular patient based on his biomechanics, envelope of function. So what we did in this case is we placed multiple implants, a traditional screw-retained acrylic PMMA type prosthesis performed by this general dentist and this laboratory technician. So I'm quite pleased in how he looks. He's quite pleased in how he looked. We could argue about occlusion. We'll talk about occlusion in just a minute. But the reality is this particular treatment took a number of months to provide because the general dentist who was doing this was doing his first case. I don't have the benefit of people who are prosthetically trained or have had multiple years of specialty service in their community. This is a young general dentist who wanted to do his first case, and he did as good a job as he could do. This gentleman, similar situation, hates his teeth. They hurt all the time. He's been missing his posterior teeth for a number of years, so we sought a different solution for this patient. We used the Malo technique that was alluded to just a minute ago by my introduction, and I used the Brandemark technique on the lower for this particular patient. That was the plan at least, and here's the execution of this plan. This is a very experienced general dentist with an experienced laboratory technician, and this is a zirconia with a composite veneer over the top of the implant substructure. So we started there, we end with that type of prosthesis. This lady, another referral from a very competent general dentist, unfortunately periodontally is relatively sound, but is losing her teeth due to recurrent cervical decay and some endodontic failures. In this case, we used a modification of the all-in-4 plan that's come out of Italy called V2V. Basically, the only distinction between this and all-in-4 is that there are two implants placed in the tuberosity, and you have a, again, screw-retained fixed prosthesis in this particular patient. And in this bar design, this is a different bar design with acrylic and PMMA teeth done by a different laboratory technician. So she starts there, she ends there. This is probably the most challenging case that I've ever had to do. We had caries, periodontal disease, combination syndrome, gagging, choking, and he is one difficult human being to deal with. And he is about the size of an NFL football lineman. Tremendous musculature. So basically, we threw everything in the kitchen sink at him. This is using Tom Balsi's zygomatic pterygoid approach with Brandemark implants on the lower. This was his immediate loading situation, and then his final prosthesis done by a prosthodontist, and again, a very, very experienced laboratory technician. His brother, he has a twin, his brother had the same rehabilitation dentist in New York City, almost done the same way. So basically, I just copied what some guys in New York City did for this particular patient because his brother was doing relatively well, so we felt this was a good engineering system for this particular patient. So we started there and we ended there with his particular treatment. Now, how we got there was completely different for each patient. In two of the patients, we did what I call analog surgery, which is flap surgery, degloved the maxilla, reduced the maxillary alveolus by an appropriate amount, used a malleable guide to place the implants in a hand fashion, and then used multi-unit abutments. The other two patients were treated, one was treated strictly with a Noble Guide computer-aided approach where we had a previous prosthesis that was done after the patient was edentulated and then placed the implants through the guide and then did immediate loading. The gentleman I just spoke about last was actually a combination approach. We placed the four corner implants, the table legs, so to speak, with a guide, and then did the zygomatic implants with a flapped approach because that's not approved for use with the zygomatic implants. So it was a combination of flap and guided surgery. So completely different protocols to solve these problems surgically. There is nothing quick about immediate loading or all-in-4. Everybody says, oh, why are you in a hurry to do it? Are you in a hurry to restore this patient? That's what I heard all-in-4 is about, is how fast can you do it? I don't think any of these patients were treated quickly. 27 months, it was the longest, 9 months was the shortest. And the reason 27 months was done is we were working with a young general dentist who didn't know how to do the protocol. He only could charge the patient so much per arch, so we did one arch 1 year, we did one arch the next year, and that's about as fast as he goes because he couldn't pull the trigger and tell the patient this was going to be this many $1,000 for his rehabilitation. This is my reality. So you better make provisionals for these patients that are going to hold up for 27 months if you're going to do this kind of dentistry. You can see that I'm not a one-trick pony. All-in-4 is one of the modalities that is available for the total edentulous patient. 4 new patients, 4 different situations, 4 happy completed patients is what we're trying to achieve. Because happiness, I think, is very, very important. It's important because the patient experiences, in my opinion, is what dictates the foundation for evidence-based care. And evidence-based care is 3 things, so let's define it. 1, it is the scientific literature. 2, it is your experience as a clinician in providing care to patients. I think that's critical. Ron Nevins did the best job, I thought, possible in this symposium of showing, 35 years of his experience in treating periodontitis? And the third and most important leg of evidence-based care is the patient experience. I want to share with you a few patients' experiences.
I believe you had a phone call with your mother.
Yes.
The night of the surgery, or
Right.
right after the surgery.
Right.
Tell me what your mother said.
She said she thought I would be in bed, groaning in pain, and I told her no, I didn't have any discomfort. And I went by the next day to see her, and she couldn't believe how good I looked.
Surprised you so far about this process?
I guess that I didn't go through any pain. I anticipated pain with the gums. I anticipated just all around pain, and I just put it off for that reason. I had thought I would want to be knocked out to have this done, and I found out that that was not necessary. And I can honestly say I haven't even realized I have these teeth in my mouth.
How was your experience? How did it go?
It was amazing. It really was. From surgery on, it's been great. No pain, no discomfort. I haven't been uncomfortable or anything.
So even though we did a fair amount of surgery and working with the implants in the bone, you really didn't have any pain, did you?
None.
Did
Not
that
at
shock
all.
you?
Yes, it did. It did. It really did.
Were you afraid?
Oh, definitely. I didn't know what to expect.
You didn't know what to expect, but I told you, I promised you wouldn't have much pain. Did you have much pain?
No, not at all. None, really.
Yeah.
So.
And I think that was your biggest concern, one of them.
Oh, yes, it was. It was.
Now, 50% of patients aren't coming to us because of the fear of pain. What an opportunity we have to prove to people we can do this treatment without experiencing pain. 95% of my patients in my practice are treated just like Dr. Brandenmark treated them in Sweden. 20 milligrams of Valium, local anesthetic, and headphones with music. That's how those patients were treated. If you can convince the population of dentists in your community and the population of patients in your community, you can treat them with dignity and respect, interact with them at the same time, and provide them this level of care, you're going to get a lot of referrals. That's my opinion. So my opinion also is All-in-4 is a great technique, but it is only one of the protocols or particular portfolio of options available that is non-grafted. And the key word here is non-grafted. This symposium has shown tremendous number of grafted cases. I will not be invited back to a graft symposium. Not that I don't do grafting. In my opinion, the partial edentulous patient is the key area that we need to do a lot of grafting for. The single tooth we do minor grafting for, as Dennis showed. In my opinion, if we can treat total edentulous patients with no grafting, that's important, not for us as a professional. Because bone grafting, we could be in the bar tonight talking about bone grafting like, walking across the street. But the truth is, as soon as you mention the word bone graft to a patient, what do? First of all, where are you going to get the bone? You taking it from me? They don't know we can get it from a bottle. The first thing they're thinking is you're going to get it from me. And if you're going to get it from me, that's going to what? Hurt. And if it hurts, it means I'm going to have pain. And if I'm going to have pain, I'm not going to do it. That's 50% of our population right there. So if I can tell the patient, we have multiple non-grafted solutions that we can solve your problem of total edentulism, how much motivation do I need? I don't need a lot. Is there literature? I said literature is important. There is a tremendous amount of scientific literature now on All-in-4. When I started it in 2005, not only was there no literature, there wasn't even a brochure to do the procedure. But now we have multiple studies done showing clinical success rate in the maxilla of 96.75%. In the mandible, 98.72%. We would expect higher in the mandible. The longest term study published is by Malo, was published in the ADA recently, 10-year data, 93.8%. And I think he would admit that the reason he had more failures was he was doing the beta and he was doing the testing and he was pushing the envelope. But the truth is, there is a tremendous amount of clinical research to support this particular procedure. If that wasn't enough, I can tell you I have spoken enough that people still don't buy it, given multiple papers. I had to write a paper last year that was published in September in the Evidence-Based Dental Journal that was sent out to all the graduate students in perio, pros, and oral surgery, an evidence-based protocol showing that All-in-4 actually did work. And what we did in that paper is provide the readers with my multi-style techniques to treat the total edentulous patient. And my cumulative success with these patients is 98.72% in the Journal of Evidence-Based Dentistry. So I think there's reasonable evidence now to support these particular procedures. But as our last speaker talked about, there's laws and principles that you have to adhere to if you're going to put 4 implants in to be successful. Because we have these very complicated prostheses with bone that's not homogeneous. We have fixtures, we have abutments, we have abutment screws, prosthetic frames, and we have teeth. And they're all subjected to stress. Stress equals force over area. That is a principle that is in physics, and that's a principle that Carl Misch harps and teaches. They are very complex appliances. We've had presentations showing there's different materials, different modulus of elasticity, and they're under compressive and tensile and shear forces on the prosthesis. Here's where the difficulty I see coming in, because we were talking about this at the bar the other night, I came out of the era, Dennis, where we saved all the teeth. We did periodontal surgery, we did root amps, we did crown lengthening, we did post-cores, we did impressions, and we did pen-style full mouth rehabilitations. That's where periodontics was when I graduated from perio school. So I understand the principles of fixed prosthesis. I also was an undergraduate and took all the removable courses, but the truth is, implant dentistry is a hybrid compilation between fixed and removable principles. And there is minimal research and study. Dennis, here's some studies you guys can do at Columbia. We don't have much data on how to design occlusions for these fixed prostheses. We have theories of fixed, we have theories of removable, but we really don't know how well they hold up, and this is what the previous presenter talked about. And I'm going to challenge us as dentists to not think of those problems as complications. The wear of teeth on a prosthesis is not a complication. That's an opportunity. It's an opportunity because the truth is these structures, which are called statically indeterminate, we don't even know how they work. The father of bioengineering, Richard Salick, said, we don't know how they work. We know that people bite on them. We know there's posterior cantilevers. We know there's loading zones. There's anterior cantilevers. We know some people chew more on one side. We know some people chew like cows. We know some people chew like birds and rats. We know that they're subjected to force. There's nobody in this room would probably disagree biomechanically that minimizing a cantilever is a bad thing. Having big implants is good, having surface area is good, splitting them together is good, shortening cantilevers is good, and having a decreased AP spread is all good. These are the things that All-in-4 does to address the formula of stress equals force over area. But the reality, and this is again, when I talk to graduate students, dentists, the first thing I tell them is you need to get this concept right away or you're going to be in trouble in implant prosthodontics and dentistry. Implants are not teeth. I don't care if they're tapered design, straight design, what company makes them, implants are not teeth. But also, teeth are not implants. And this is where opportunity comes in. I don't care what dentist you are, what town you practice in, what team you have. The reality in dentistry is if you've been practicing long enough, you know that patients will fatigue things, they will fracture things, they will overload, they will wear, they will spall them, and there will be combinations over time. But those are not complications. Those are opportunities to do another prosthesis. I mean, if patients didn't break teeth, raise your hand. If patients didn't break teeth, what would we do in this room? Sell insurance, somebody said. Then we'd be having an insurance convention. But the truth is, these things will wear. Our goal is trying to get them to wear and break the fewest number of times possible, right? And when it does break, to break in a manner that it's easy to fix. But the truth is, everybody in this room that drives an automobile has tires that wear out. When you show up at the tire guy, he goes, well, that's a complication. Your tires are worn. He goes, no, we have a new set of tires. Let me take you over here and get a new set of tires. I mean, when you buy the tire, they say it's going to last 30,000 miles. I just bought a car, Maurice knows this, the tires last 4,000 miles. And if I let Maurice's son drive it, they'll last 2,000 miles. So these things are going to wear. We just don't call them complications, they're opportunities. In the literature, though, we have to call them complications. Those are complications. No, it's opportunity. Now, what are our goals? My first goal with All-in-4 is to lessen the disability. If I have a periodontal patient who spent 20 years saving their teeth, do I want to take their teeth out and let them wear a denture? I don't think so, because I've been trying to lessen your disability for 20 years by keeping your teeth. So you're not going to get a denture. I want to preserve the bone. People say, are you really a periodontist or are you an oral surgeon? I think it's philosophically totally in agreement that either I save teeth or I save the bone with implants. End of story. I have no problem with that. I want to immediate load. That's my goal, but here's the problem. It better not be my promise. If you promise a patient you're going to do immediate load, and you find that the implants don't torque into the bone to a satisfactory torque level that you can immediate load it, and you've been promising this patient you're going to immediate load it, what do you think you're going to have when you look at the patient and say, well, I can't immediate load you? We're going to have a happy patient or unhappy? We're going to have an unhappy patient because you didn't pave your way with words. You know, Dr. Goldstein, he is a master of words. Is he not, Maurice? He's a master of the psychology of treating patients. And I can guarantee you he would be very careful in not promising that you're going to get immediate load. Does it reduce treatment costs? From the company I consult with, do you think they'd rather have you do All-in-8 or All-in-4? What do they sell? A lot of titanium. But now this company has been branded with, they're the All-in-4 people, okay? Well, they'd like you to do All-in-10 from their business model standpoint. So does it reduce cost? Here's who it reduces cost to: the patient. I want to treat more of these people, not less of these people. My goal in St. Louis is to have nobody have a maxillary denture, period. So if we as a profession can offer patients the opportunity to get this treatment and put fewer implants in and get the same result, what's the problem? Oh, by the way, I charge the same whether I put 4 in or 6 in. Does it take any longer to put 4 in or 6? How much longer does it take to put 2 more implants in? 5 minutes? Maybe. Maybe we need to sell solutions. I look at it as facial rejuvenation. To me, it's a philosophical alignment. Some of you say, oh, that's a business model. Putting forward, it's not my business model. My business model is to treat the individual patient based on the individual needs of that patient. Whatever it takes. Whatever it takes. Yes, there are alternatives. I didn't say I was opposed to bone grafting. By the way, I'd like to be invited back to Synergy or the bone grafting conference because I do it. I don't want to be branded as a non-grafter. But the truth is, didn't one of our speakers say 40% of bone graft cases possibly have complications? Did I hear that right? Did I hear that right? So let me see, Mrs. Jones. You don't like bone grafting. And by the way, if I'm ethical and honest, I would tell you that I was just at this conference and one of the speakers said there's a 40% likelihood you could have a complication doing what we're doing. Oh, sure, I'm just going to be doing this right and left. By the way, you can buy these tires, but in about 100 miles, you'll have a blowout and flip over your SUV with your kids in it. I don't think they're going to buy my tires. Less pain, less disability, no bone grafting, less invasive, less swelling, and we have good, better, and best options for the prosthetics. This is not, here's my take on it. This is not hard to sell to patients. You know who this is hard to sell to? Dentists. Oh, I do overdentures. That's cheaper. Not in the United States, it isn't. Look at your lab fees for overdentures right now. They're higher than doing fixed prosthesis. If you do good, it's cheaper than doing overdentures. And, in my opinion, you don't have the maintenance nightmares of the attachments. And that we have good attachments. I'm not saying we have good attachments, but you still have to maintain attachments. How do we execute? Begin with the end in mind. There's a first mental creation and a second creation physically. We are replacing tissues, and as we replace those tissues, we need 15 millimeters to replace those tissues. We need 10 millimeters for teeth, 3 millimeter by 3 millimeter bars, 1 millimeter veneers of veneering materials. We need 10 millimeter or less distal cantilevers. This has been founded in studies, FEM studies, that tilting is safe, reduction of the cantilever is safe. There's really no difference in FEM studies between all-in-4 and all-in-6. Why put 6 in if 4 is the same? Limit your cantilevers to 10 millimeters. Rigidity is needed. John Brunsky in a new textbook just said, if tilting is engineered correctly, which means strains and stresses are kept in with danger limits, that tilting can be safe and effective. And the way we do that is through proper bar design. There's different bar designs depending on how you're going to make the prosthesis. These are the good prosthesis. This is the traditional bar wraparound with acrylic and PMMA teeth. This is what it looks like occlusally today, and our previous presenter talked about it. We have substructures that we can laminate with porcelain or composite. We use the same traditional rules that we've used in cosmetic dentistry and prosthetics. We can use copy mill patterns and cutbacks, and we can laminate with porcelain, composite, either hybrids or nano composites. We have to look at, well, what are we opposing? Do we have teeth? What's the envelope of function? Vertical versus horizontal chewers. I do believe we need protection splints for all these patients. Not only permissive protection splints, but you need athletic protection splints, especially if these people are involved in activities where they might injure these teeth. So my final thoughts. Edentalism has a negative impact on people's lives. We as dentists have many tools to treat it. There is evidence-based dentistry to support its treatment, and biomechanical principles are important. The future is in logistics. The present scheme of logistics is that we do have to take impressions, we do have to do traditional dentistry, but at the end of the day, we get prostheses that can be designed through scanning and through central milling services and can be laminated with many different materials. The future, and this was talked about by several presenters yesterday, will be we will no longer take impressions, we will be using scanning devices, we will be using virtual articulation, we will be using in-office and central milling procedures to provide prostheses, and this was Brandemark's charge to me almost 4 years ago. He said, it's been complicated. We need, and his philosophy is, to make this technology is available to the masses. He hopes that we will simplify procedures and we will make them more readily available for those patients suffering from edentulosum. Thank you very much.